Alright, we're going to cover hemoptysis, that is the causes, categories, and workup of bloody coughing. If you have a patient that presents with coughing up blood or hemoptysis, the first thing you have to do is rule out other possible sources of blood. So blood coming from the nasopharynx is called epistaxis. That can look like hemoptysis but not actually be. And then blood in the upper GI, hematemesis, can also present and look like hemoptysis but not actually be. So you want to first look up the nose, look at the nasopharynx, and in some cases look to see if there's a source of blood in the esophagus or in the upper stomach. In the U.S., hemoptysis is most commonly caused from bronchitis due to a bacterial or viral infection. So the U.S., we're talking about bronchitis usually. In the entire world, worldwide, it's most commonly caused from tuberculosis infection. So bottom line is the most common cause of hemoptysis, period, is infection. Worldwide, it's an infection with TB. In the United States, it's a bronchitis. Alright, so to understand hemoptysis, you have to understand the blood supply to the lungs. And there's two sources of blood to the lungs. You got the pulmonary arteries and the bronchial arteries. Now, the bronchial arteries come off of the aorta, so it's a high-pressure system. The pulmonary arteries, however, come from the right from the right ventricle, so it's a lower-pressure system. So let me draw this out for you. Okay, so what I've drawn for you is, you can see I have the lungs on both sides. You have the trachea, you have the right and left bronchi. Here, of course, the heart with the pulmonary artery, the pulmonary vein, and then coming up from the left ventricle we have the aorta. So, like I said, the pulmonary artery comes from the right heart, from the right ventricle to the lungs, and so the pulmonary artery is a lower pressure system, the right ventricle having a lower pressure as it pumps. Now, the bronchial artery actually comes off of the aorta right around the arch. It can also, and it travels down with the bronchioles, and it supplies all of the blood. It doesn't exchange oxygen with the lungs, but it actually supplies all of the airway with its blood supply. Some anatomical variants, you'll remember that the thoracic aorta, they give off the intercostal arteries as it's going up and back down, and so sometimes the bronchial artery will come off of one of the intercostal arteries. So that's just one of the normal anatomic variants and stuff, but for the most part, these bronchial arteries are coming from the thoracic aorta. Now what happens if you imagine here that we have this bronchiole, and it's going in and it splits several times as it goes down into the airway. As it's going down deeper into the airway, you have the bronchial artery coming with it, and so if you just imagine that it's traveling with it, the further down it goes, the closer it comes into contact with the actual air space. So it will start far away. So if you imagine the black line is where the air space begins, it will start proximally very far from the airspace, and it gets closer and closer to the airspace the farther along the airway that you go. And so the point of that being, if you have just a slight irritation to the airway, to the surface of the airway, up proximal to the bronchus, you're not going to get any damage to the artery. But if you have irritation to the airway distal to the bronchus, then you're going to get possible irritation to the bronchial artery, and from that you can cause bleeding into the airspace. Now, another thing you need to know about the anatomy of everything is, like, whenever all of these, so the bronchus, the pulmonary artery, pulmonary vein, they all go into the lung at this area called the hilum, and then everything spreads out. So the highest density of blood vessels for all of these vessels is toward the center of the lung, toward the hilum. So the point of that is, let's say you get a cavitary lesion. You get a cavitary lesion down here, you're going to get bleeding because it's going to damage both pulmonary vasculature and bronchial vasculature. But if you get a cavitary lesion more proximally, so let me change the color to this, you get a cavitary lesion more proximally, it's going to have a higher density of vasculature, a higher density of both pulmonary and bronchial vasculature that it's interacting with, and you're going to have a larger degree of bleeding. So while it's easier to cause irritation distally, typically you'll get less blood from that kind of an interaction, whereas more proximately you'll tend to get more blood. Now the last thing I want to say about the anatomy, just the anatomy in general, is that hemoptysis can start anywhere from the glottis and go all the way down to the very base of the lung. So the glottis is where you can initially get hemoptysis, but for the most part, this lecture is going to cover hemoptysis that is generated from the bronchus to the alveoli. And lastly, of course, since we have the bronchial artery, we also have the bronchial vein. So the bronchial vein will come out. It usually drains into the azygos or the hemiazygos. Okay, so this slide basically just sums up the things that I drew out for you and pointed out. So the bronchovascular bundle, there's the highest concentration near the hilum, so you get the most massive, that will be the most massive damage. It will also cause the most massive risk of bleeding. And so that's what I said, you're more prone to a massive risk and massive damage than more distal. Furthermore, I said lower in the airway or more distal in the airway, the vasculature, especially the bronchial vasculature, comes closer to the airspace. So it becomes more susceptible to surface irritation. And then lastly is that damage to bronchial arteries can lead to massive bleeding. So the bronchial arteries are going to be your cause of massive bleeding in 90% of cases. But you also have a bronchial vein where it may or may not cause massive bleeding. I also said that the pulmonary artery is a low pressure system, so you get the pulmonary artery, capillary, and veins, and this has all of the cardiac output that goes through your entire systemic circuit is also pumped through your pulmonary circuit in that exact same time. But even though the volume's high, the pressure's low, and so it has a very low risk of massive bleeding. Now it's also important to point out, as I'm saying, massive bleeding, this is a category. There's 3 categories of bleeding. There's massive, moderate, and minimal, or some sources will say mild, but this massive bleeding, you have a low risk from the pulmonary circuit, but you still have you still have a risk of minimal and moderate bleeding from the pulmonary circuit. Now, you can usually get damage to the pulmonary vasculature or damage to the bronchial vasculature for different reasons. But when you have a cavitary lesion in the lung, you can actually get damage to both vascular supplies. So if I have a cavitary lesion, say for example from tuberculosis or community-acquired pneumonia, then I will get a lesion here, and part of that lesion was going to be supplied by capillaries from the pulmonary circuit, and part of that lesion was going to be supplied by the bronchial artery and the bronchial vein. And so by causing a cavity there, I'm damaging both blood supplies. Now imagine I have for example right here my heart, and I have this cavitary lesion in the lungs. And imagine that cavitary lesion is really close to the pulmonary artery. There's something called a Rasmussen aneurysm, which is basically the pulmonary artery dilating or aneurysm into that cavity that's nearby. And this can be left by, of course, anything that can cause a cavitary lesion, for example, tuberculosis. And so when that happens, you have a very high risk of lots of blood coming out of a Rasmussen aneurysm. So what I've done for you is I tried to make this simple. I've broken all of the etiologies of hemoptysis down into 6 large categories. So there's the alveolar damage. Sometimes this is called diffuse alveolar damage, depending on how many what the quantity of alveoli are involved. Can typically be due to vasculitis or pulmonary renal syndromes, which can also be vasculitides or autoimmune problems, and then bone marrow transplant. Now, this bone marrow transplant is sort of interesting, so I'll cover some of these things in more detail. So you got alveolar damage, you have direct physical injury. If somebody gets shot in the chest, of course that's going to cause hemoptysis. But that's not in the list here. So thermal injury, so if you're breathing in a hot fire, you're going to get damage to your lungs and possible bleeding. Inhalation, this is the same thing as many of the conioses we talked about last week. So if you're breathing in sand, it can cause irritation and damage to the airway, and you can have bleeding. Pulmonary vascular disease, this would be like heart failure. Next, we have coagulation or coagulopathies. This can be anything from hypercoagulable state, where you get venous thromboembolism, pulmonary embolism, or if you're at a over anticoagulated state, so if you're taking Coumadin or warfarin, or if you have thrombocytopenia from DIC. You'll remember that with thrombocytopenia, the common presentation is that you get bleeding in the mucosal area, and so that would include the lungs. I made another category called common and concerning. This is just common as your infections. Like I said, worldwide and in the United States, infection is the most common cause of hemoptysis. Cancer is the most concerning. Well, it's not the most concerning, but is the first thing that jumps to your mind when someone says, "I'm coughing up blood." The fifth category I have is, I call it weird medicine. This is, we're going to cover a couple of these things. Endometriosis, you can get thoracic endometriosis, which can cause monthly cyclic bleeding in the lungs. Ehlers-Danlos syndrome, which you can have a vascular type, and then vascular malformations. And then 30% of all hemoptysis it ends up being cryptogenic in one study. So just really quick, there's a difference between cryptogenic and idiopathic. Cryptogenic means like we just don't have the technology essentially to go down that far and look to find out where the bleeding is coming from, what the source of it is. So let's look at a few of these in more detail, not all of them, just a few of them. Bone marrow transplant. The exact pathogenesis hasn't been completely worked out yet, but if you have hemoptysis within the first 100 days following a bone marrow transplant, this needs to be number one on your differential. I mentioned pulmonary vascular disease, and I specifically said heart failure. There are more kinds of pulmonary vascular disease. Vascular malformation I put under weird medicine, but it is also considered a pulmonary vascular disease as well. An interesting one is a focal jet mitral regurgitation. So you got a mitral regurgitation with a very focal jet in the regurg. In those cases, you end up with an upper lobe opacity and hemoptysis. Pulmonary hypertension can cause hemoptysis, but it does so extremely rarely. So I think the take-home from this is that your heart failure and this focal jet mitral regurgitation, those are the pulmonary vascular diseases that I think are both going to be common enough and interesting enough to be testable. When you have heart failure, typically the presentation with that is you actually get damage to the pulmonary arterial or the pulmonary capillary bed that's wrapping around the alveoli. So the alveolar capillaries, you get damage to those, and so you get some blood leaking into the alveoli, but typically it presents as a pink frothy sputum. And only occasionally does it look as like a blood-tinged secretion. So like I said, it's a result from a rupture of the small alveolar capillaries. Cancer, I'm going to talk about three things. So you have, so first of all, like I said, cancers of the proximal airway are more likely to cause hemoptysis, and that's because the density of the vasculature there, which we talked about on the anatomy. The next thing is that you have basically bronchogenic, squamous and small cell, carcinoid, and Mets. Now, bronchogenic is what everybody thinks of with hemoptysis, but only hemoptysis is only the presenting symptom 10% of the time for bronchogenic. And actually, squamous cell and small cell carcinoma are much more likely to cause hemoptysis on presentation for two reasons. First of all, they tend to be centrally located, and second of all, they tend to be extremely large whenever they're discovered. Which is kind of ironic that it's called small cell, but the tumor size is usually really large. A bronchial carcinoid is a highly vascular tumor. It's not related to smoking, and so if you have a young to middle-aged patient who's a non-smoker and has hemoptysis, if cancer is on your differential, it should probably be bronchial carcinoid. And then the last type of cancer, usually you're going to get METs from renal cell, METs from breast cancer, METs from prostate. So you're going to get a lot of different METs will show up in the lungs, but typically they're going to be small nodules, and they're going to be placed toward the periphery. They usually don't cause hemoptysis, but whenever you have hemoptysis and you see several small nodules on x-ray, METs should be the likely diagnosis. Okay, infections, typically bronchitis, like I said, TB also, and there's so many, it wouldn't be impossible, but it would be unlikely for anyone to need to memorize them all at this point. Endometriosis, this is an interesting one for me. So typically, of course, you know that we have the uterus, and from the uterus you get the ovaries and everything coming off of that from the uterine tubes. So here in the uterus you have the different layers, and the top layer is the endometrium, and the endometrium every month under the influence of hormones will proliferate and grow, and it will grow a large vascular supply with it, and it has all the signaling mechanisms it needs to produce the vascular supply. And then at the end of the month, when those hormones change for anywhere from 3 to 9 days, you can have bleeding because all of this stuff will undergo apoptosis, and the blood supply will die with it, and you'll get a monthly menstrual period. In a disease called endometriosis, typically some of this endometrial tissue will travel up through the uterine tubes and get out into the abdominal cavity or into the pelvic cavity and other places, and it can grow and die under hormonal influence in other cavities of the body. And when it does, you get internal hemorrhage, and you get very, very painful presentation of endometriosis. In very, very rare cases, you get something called thoracic endometriosis, where this endometrium can actually get into the lungs. When it does that, so if you ever have a case where a female is presenting with hemoptysis, if the hemoptysis goes away and comes back on a monthly cycle, on anywhere from a 25 to 35 day cycle, then this is going to be high on your differential. So even though this disease would be really rare, the pattern is very specific for that disease. There's several ways of categorizing hemoptysis, but in almost all the sources that you're going to read, you're going to see this categorization based on the amount of blood. So massive hemoptysis, moderate, and minimal hemoptysis. Okay, so massive hemoptysis, this is defined in a couple of different ways. So you'll see it defined as anything between 100 and 600 milliliters in a 24-hour period. I like the up-to-date definition. They said they classify it as 500 milliliters or greater in a 24-hour period, or a rate of 100 milliliters per hour or higher. 90% of these cases are going to be due to damage to the bronchial artery. Remembering that this is a high-pressure system is the key to understanding all of that. So this is a medical emergency. You got to work it up quick, so you can actually drown on your own blood. Moderate and minimal hemoptysis. So minimal is going to be less than 30 milliliters in a 24-hour period, and moderate is going to be between 30 and 500 milliliters in a 24-hour period, but less than 100 milliliters per hour. You can see by this range, this is the widest, most variable category in this classification. Alright, so your workup, we're going to go through what is the workup for hemoptysis from the physical exam. We're going to look at radiology and imaging, and then labs. So the first thing you're going to do on physical exam, if it's not a massive hemoptysis, you're going to take your time. But the first thing you're going to do is you're going to check for nasopharyngeal bleeding or epistaxis and GI bleeding, hematemesis. Now, checking for GI bleeding may not be as simple as just saying check for GI bleeding, but if you have looked in the back of the airway from, just looking in the mouth and stuff, and you have no suspicion of GI sources of blood, then that should suffice for that time being. But if you can't find another cause of bronchial or of pulmonary blood, then you should go back and re-examine the GI more carefully. Next, we're going to look at sources of bleeding that may be due to heart failure. So you'll look at the lower extremity. You look for edema in the lower extremities. You'll check the JVD. You'll look for clubbing. Clubbing is going to indicate that you have some type of pulmonary oxygenation problem, and so you're going to be looking for things like maybe bronchiectasis with cystic fibrosis or any type of thing that could prevent oxygenation. This can clubbing can be seen in a number of pathologies, but you just check for that as well. You also look for mucocutaneous telangiectasias. This would be Rindu-Osler-Weber disease, where you have a pulmonary vascular malformation. Then in the physical, you're also going to ask about the timing of the bleeding. Is it monthly? Is this the first time? Is this the second time? Because working up from the first presentation of hemoptysis will be very different than working up the second presentation or recurrent hemoptysis. So in general, with radiology, I'm going to give you this outline. You're going to do X-ray. If the X-ray doesn't find anything, you're going to do a CT, and it can be a high-resolution CT. And if you don't find anything, then you're going to do bronchoscopy. So if you do an X-ray and you don't find any reason for concern from the X-ray, and there's very little blood there, so you have minimal, less than 30 milliliters in 24 hours, minimal blood, X-ray shows no cause for concern, and you have a high clinical suspicion for bronchitis, you stop there. But that's almost the only time you're going to stop if the X-ray is normal. If the X-ray is normal, you don't find anything, you don't have any good reason to think of something else, you go and you do a CT. So 10% of normal chest X-rays with hematemesis are going to have a lung cancer or a bronchial cancer. Furthermore, you can also still miss cancer with a bronchoscopy, and because of the invasiveness and the chances of aggravation irritation, you're going to move straight to the CT, which the difference between the biggest difference between the CT and the bronchoscopy is, even though the bronchoscopy can find the source of the bleeding, CT can also find the source, and usually the CT is better at finding the etiology. But sometimes the CT fails, and when it does, we hope the bronchoscopy doesn't fail. So like I said, the clinical picture, very important. So no further workup is needed when minimal or moderate hemoptysis, clear chest X-ray, first presentation, and high suspicion for a specific etiology, especially bronchitis. Bronchoscopy is done in last resort. And then the other kind of imaging you might do is an echocardiogram, because you want to evaluate cardiac function when you can't find any specific disorder with the with the lungs and the lung vasculature. So the American College of Radiology's put out appropriateness criteria, and this is the ACR appropriateness criteria for hemoptysis. So you'll notice they have 3 different variants, and in all variants it starts with the chest X-ray, it moves to a CT, and then of course at the very end you may do other tests. I don't think that the ACR puts in their appropriateness criteria in these charts. They don't put the bronchoscopy because I believe the case is it doesn't have any type of radiation. It has different indications. But if you go and read the paper, the ACR appropriateness criteria for hemoptysis, though it was updated in 2014, they talk about using bronchoscopy as a final resort after CT if the CT fails. Okay, so we've done physical exam, we've talked about imaging. The other thing is lab tests. So your main thing you're going to check for in lab tests is you're going to check for hemostasis, renal function, and infection. So of course you do a CBC and hematocrit, you want to get platelet count, so primary hemostasis. You're also going to do coagulation studies for secondary hemostasis, and then you're also going to want to know the patient's history. Are they on anticoagulant medications? You do an immediate urinalysis and serum chemistry, so you want to check for the kidney function. Is there acute renal failure? If there is acute renal failure on presentation with hemoptysis, you're going to highly suspect what's called the pulmonary renal syndromes. There's several of them, but you go ahead and you'll run an ANA, an ANCA, an antiglomerular basement membrane antibody, and check for all the vasculitides and the autoimmune diseases that can cause the pulmonary renal syndromes. If sputum is produced, so hear me again, I said if sputum is produced, you're going to do the staining and culturing for bacteria. So if you don't have sputum produced, the likelihood of having bacterial infection is pretty low, but if sputum is produced, you're going to do a sputum culture, a gram stain, an acid-fast stain, rarely a silver stain, and then of course you may follow that up with tuberculin and quantiferon. And this is especially true in other parts of the world where tuberculosis is your #1 cause of hemoptysis. Lastly, I included this workup table. This comes from Harrison's Internal Medicine on page 246. And so you're ruling out other causes. You're asking yourself, is it mild, moderate, or massive? And then you're going from there to do your workup. In mild, with no other risk factors, you may go into treating your primary suspected cause. But if there are other risk factors, you're going to move in and do your imaging and your lab work. Alright guys, that's it.